Okay, welcome and thank you for joining us this afternoon for Northwestern's Robert J. Havey, MD Institute for Global Health webinar, bringing primary care to the global stage, why now and what's next. My name is Jen Burke. I'm a member of Feinberg's Development and Alumni Relations team for the Havey Institute for Global Health. Today's event will begin with a welcome from Dr. Robert J. Havey, followed by a presentation from Dr. Lisa Hirschhorn with a moderated discussion afterwards. Now I'm pleased to introduce Dr. Robert J. Havey. Dr. Robert Havey is the Deputy Director of the Havey Institute for Global Health, Director and founder of the Global Health Initiative Fund, and Clinical Professor of Medicine at the Feinberg School of Medicine. Dr. Havey has been in practice at Northwestern for over 35 years, where he is currently the Medical Director for Northwestern Primary and Specialty Care and a Vice President of Primary Care Operations for Northwestern Medical Group. He is a tireless advocate for global health and for the importance of primary care in all health systems. Northwestern University Feinberg School of Medicine's Havey Institute for Global Health has a mission to expand knowledge, capacity, and equity in global health through transdisciplinary research and education partnerships. Thank you, Dr. Havey.
Thanks, Jen, and welcome everyone. Thank you for taking time to tune in today. We have tried to keep a tradition going of some periodic webinars over the last several years to bring people up to date with some of the activities of the Institute. This is a timely topic because we have focused in the last several years on infectious disease and particularly on COVID, as we've all been navigating the pandemic. And as that is falling into the rearview mirror, we are back to what we started with all those years ago. For those who don't know me, I'm an internal medicine doc at Northwestern. I have been here a long time. I've been a long and believer and kind of very strong advocate for primary care. And so talking about global primary care is something that resonates pretty strongly with me. I've said from the beginning, when I started becoming involved with global health, that about half the world has really no access to modern health care. We've talked about a lot of healthcare issues over the years. The Institute itself has been built and grown and currently constructed of 10 different centers that address a lot of different global health issues from different points of view. Primary care is a unique center, but it happens to be an umbrella that encompasses a lot of the other centers in the Institute. It's a fact that a lot of people don't appreciate when we talk about low and middle income countries and we talk about poor global health, that currently non-communicable diseases actually are more important in global health issues than infectious disease. People sometimes think of not just COVID, but they think of malaria and tuberculosis and hepatitis and infantile diarrheas and intestinal infections as a leader in mortality and morbidity. And yet, as the world has gotten not just larger, but a little bit more mature in some of the health systems, these non-communicable diseases have really taken over. For example, 3 out of 4 people who have high blood pressure in the world live in low and middle income countries. And yet of that large number of people with high blood pressure, only 10% of them have their blood pressure controlled. It's a surprise to a lot of people that the leading cause of death and disability in the whole continent of Africa is actually hypertension. It's not malaria, it's not dengue fever, it's not Ebola, it's hypertension. So when you hear from Dr. Hirschhorn today about what we're doing, and you wonder, why are we talking about things like blood pressure? We have to be realistic about why half the world is held back in terms of their economies and their productivity and their general health. It's not just infectious disease, it's other things. So how do we kind of maximize our input from this Global Health Institute that myself and Lisa and so many others are involved in? We have to do it not just based on our organizational structure of 10 different centers, but we have to start with primary care. A lot of the people on the line today might know me personally. I might be their primary care doc for a year or 30 years. Those who know me, and this is not a play for myself, it's a play for primary care, kind of appreciate the role of a strong primary care infrastructure and healthcare management. I run recruiting here at Northwestern, and I remind everybody I recruit who is interested in a career in primary care that what we do is simple on the surface, but complex in implementation. We prevent things, we diagnose things, we manage things. And that underpinning of a primary care health system to kind of identify disease, find it early, prevent early death, manage chronic problems, that's the key to primary care. It's just easier to define than it is to put into motion. And that's why we've really created this primary care center within the Institute of Global Health. We're really fortunate that this is the one center in the Institute that's been endowed. And so this is, we're proud to say, the Ryan Family Center for Global Primary Care, endowed by the Pat and Shirley Ryan family, given us a great endowed funding that will allow us to do this work in perpetuity forever, and really keep growing primary care infrastructures around the world. I'd like to introduce Dr. Lisa Hirschhorn, who is our director for the Ryan Family Center for Global Primary Care within the Institute. She's a full professor of medical social science. In addition to being our director, she's an expert in implementation research, improvement science, and patient-centered outcome research. She actively applies all those methods to improve the quality of care in resource-limited settings. She's expanded her work to focus on strengthening primary care, including reducing the burden of cardiovascular disease, improving care for a growing aging population, and focusing on maternal and child health, all in low and middle income countries. Her background in implementation research is critical for us to accomplish our goals because we can identify a lot of problems and we can come up with a lot of grand plans of how to impact the problems in global health. But if we can't come up with a strategy to implement the solutions that we're devising, we won't have any impact. So we're really blessed to have Lisa as our leader in this critical center, because that's where we have the strongest possibility of a really high scale impact on global health around the world. So it's my pleasure to introduce Dr. Lisa Hirschhorn. Thank you.
Thank you so much, Bob. And let me do the share screen. There we go. So let me just get rid of a couple of quick things. Okay, excellent. Well, Bob, thanks again so much for this opportunity, and thank you to everybody who is dialed in to hear about this. It's very exciting to me that we have a lot of interest in primary care. I think when we first started to talk about this, people were looking at us like, why are you talking about this? Why is this important? So I'm going to talk about sort of a little bit of the history. So the sort of primary health care, that it's always been important, but now more than ever. And then really spend a bunch of time talking about what are we at Northwestern University doing to help. So primary health care has been around for a very long time. And in 1978, there was sort of this recognition that even though it had been recognized as key, that it was really struggling. And the idea was to sort of have this call to action, and it put primary health care really on the global agenda. So again, this was before HIV, but most of the focus had been on tuberculosis, malaria, childhood disease, maternal health, all very important, but was really focused more on the disease rather than on the person. In 1987, there was a new initiative, again, still trying to figure out how do we make it better, the Bamako initiative. And in 2006, another initiative, Abuja, the call for rededication to primary healthcare services. And these sort of calls kept on going until finally, I think a big wake-up call happened in 2014 when the Ebola epidemic highlighted the importance of strong primary care as a first response of identifying health emergencies, responding to health emergencies, and very importantly, helping with recovery. So if we go back to 1978, it was a turning point. So it really got people's attention. The statement, it was essential healthcare based on practical, scientifically sound. So again, bringing research results in there, but also socially acceptable methods and technology. and that these should go to everybody everywhere. So if we look at what happened in the last century and the first couple of decades here, enormous number of innovations, what we call evidence-based interventions known to reduce suffering and to reduce death. But the problem was they weren't getting to everybody. And even when they got there, they weren't getting there with high quality. So we found that 40 years later, there are major gaps in primary healthcare delivery in many countries, including low and middle income. This huge loss of trust and confidence in the system that started with the Ebola outbreak, and we've certainly seen that as well with the COVID-19 pandemic. And overall, really poor quality of care delivery, complicated by inadequate resources that Bob's already talked about. So the question is why? And that's really what we spend a lot of our time thinking about, is not just why, but then what do we do about it? So the problem is that many people forgot the core principles of primary care. And so what are they? Barbara Starfield, a number of years ago, sort of talked about these interconnected functions. And these start off with the first contact. When you get sick, who do you go to? Probably a number of you have Bob Havey's cell phone number. He's your first contact. So rather than bypassing and going to the hospital or not going for care, that trust is associated with your first contact. The second is that it should be comprehensive. So we shouldn't just be thinking about an HIV problem or a tuberculosis problem, but it should be, as Bob talked about, going all the way from prevention and promotion, healthy lifestyles, to curative and even when needed, palliative care. But to do this, it has to be coordinated. So it can't just be one person, there's many specialists, and we need to make sure, again, that that care is seamless. And very importantly, it should be accessible, so offered within people's communities at a price they can afford. I work in Liberia, where people live up to 20 kilometers from the nearest health center. So how do we do that? Through things like community health workers we'll talk about. And then it has to be continuous. So it has to connect people, whether they're at their primary care, going to the hospital and coming back to the GEM, across their healthcare needs. And then very critically, and this was really something that I think occurred just in the last 20 years, it has to be people-centered. So instead of having these programs, vertical programs, we call them, I'm doing HIV, I'm sorry if you're pregnant, I'm not going to talk to you. I do maternal health, but if you have malaria, I'm not going to take care of you. To make it people-centered so that it's interconnected. So this renewed focus was really finally recognized. And the idea was that you have this sort of primary care, which has to be, again, not just in the way we deliver, but also in the policy and the actions, that it has to empower the community to know what they need and to ask for it. And basically, we have to continue to build capacity for people to deliver high quality care. And it's very linked with this big focus on universal health coverage. So again, this is access, quality, and financial protection. A lot of people in the countries in which I'm working get devastated because the amount of money that they have to spend for a condition that was potentially preventable will bankrupt their family. So somebody who's not diagnosed with hypertension, who goes on to have a stroke, the cost to the family is indeed enormous. And that all leads to this big movement, what's called the Sustainable Development Goals. And these are all focusing and critical for good health and well-being, also known as the Sustainable Development Goal 3, or SDG 3, for those of you that like acronyms. So why is this? And as Bob talked about, this is now more than ever. So we have this increasing rates of chronic disease, which requires expansion from this acute disease focus, one-off, I have malaria, I have diarrhea, I only need to do one and I'm done, to really focus on people in the lifespan. And as Bob pointed out, less than 1 in 5 people with hypertension are in treatment and controlled. We have, again, so many important prevention and treatment discoveries which are not getting to people. And very importantly, there's growing populations of adolescents because we've reduced deaths among children, but also as people are living longer in older populations. So for example, in 2020, 510 million people had uncorrected near vision impairment. I probably would not be able to be giving this talk without my own reading glasses. And then, of course, not just COVID, but also future pandemics. And the idea of a resilient, robust health system, really relies on primary care. So the question is, which I spend a lot of my time thinking about, is again, why don't they get it when it's available? So let's say we've expanded out, and the problem is, again, barriers in access. It costs money that people don't necessarily have, either to pay for the care or to pay to getting the care, or there's just geographic access. So again, going back to Liberia, 20 kilometers from the nearest primary care center, but also especially when things happen like floods or bridges that go out or conflict, people can't actually get there. But there's also problems in the way that care is sometimes delivered. And we know that when people have poor experiences in care, what we call the demand side experience, disrespect, unmet needs, lack of trust, they will bypass primary care or they just won't go to get it. We did some work in Rwanda where we found that children under 5 who died went to the health center, but when they still didn't get better, they didn't go back because there wasn't this idea of continuity and trust. So there's a bunch of emerging solutions, and some of these come from low and middle income countries, but some of them come from here in the US. So one of the important ones is what we call empanelment. So that's a provider or a health center knowing who are they responsible for. I would bet you if I sat down with Bob Havey, he could probably tell me, although he wouldn't because of HIPAA, the names of all the people that he is responsible for. And this is a concept that's actually now being implemented in these systems in low and middle income countries that are not used to having this kind of longitudinal care. They need to know who they're responsible for, who's showing up and who isn't showing up. A focus on integration, not vertical programs. So the best funded programs in low and middle income countries still remain some of the ones that Bob talked about. PEPFAR for HIV, saved millions of lives. I'm originally an HIV provider. But the idea is we need to integrate these programs, hypertension and HIV, for example. Something that started in low and middle income countries, but is actually increasing in the US is task sharing. So increasing the role of community health workers who are trained and salaried and supervised to provide some of that first contact care, addressing the barriers of affordability, acceptability, and accessibility, but also structural changes to improve quality. Some of the work that's come out of Northwestern through Nest 360 to improve quality of care for newborns, interdisciplinary, and then some of the work that I find the most fascinating and interesting and is really supported through the center, learning from the US to low middle income countries and backwards, low middle income countries to the US. So what are we doing here at Northwestern at the Havey Institute for Global Health? So again, as Bob talked about, we now have this global primary care at the Havey Institute of Global Health through the Ryan Family Center, which is forever grateful for. And the mission for this, was newly established, is to strengthen the global and local efforts to improve global primary healthcare quality and equity through partnerships and innovation in research, education, and service. And I'm going to give you just a couple of examples of what we're doing. We don't have time to talk about everything, but happy to talk in the future. So how are we doing this? Well, first, we're supporting the training of the next generation of primary healthcare providers, both from Northwestern as well as partner institutions. And very importantly, we're developing research collaborations to bring new knowledge, as well as to build capacity for this kind of research in the future. This is just a couple of pinpoints of where the center is currently partnering with people. You can see we're largely based in with African partners. It's sort of based on our history, but we're moving out into the Asia and also in Central America, and hopefully very soon one in Latin America as well. So these are just a couple of examples of work that we've worked with partners with to be able to do. So the first was a question that came up during COVID-19, which was, as we know, there was tremendous interruption of care, particularly in primary care, including for mothers and for babies. And this actually was caused a suffering and death. And so the question was, well, if you put in place a trusted primary healthcare system that includes community health workers, what actually happens? And working with this group, what we found was that care was maintained despite COVID-19. And we actually talked to the community and found that community health workers were key to the trust and the access, as well as having actually built respectful and well-stocked and well-staffed health centers. And what was equally exciting is that this actually helped spread the knowledge to inform scale up in Togo to new countries such as Guinea. And then led by our partner, Kevin Fiore, who is a associate professor at Montefiore in the Bronx, that these are actually being implemented in the Bronx in New York City, which is one of the areas in the US which has some of the worst health outcomes. And what you can see here is some of the community health workers, and actually Renee Whiskey, who's the leader, came with us to Togo to learn about this. And we've been working with them how to capture information to spread this back. Another very, very exciting scope of work is working with colleagues at the Medical College of Lagos and Lagos University Teaching Hospital about healthy aging. So as Bob pointed out, the population is aging and there's growing needs to improve their quality of life and their care. Now, the World Health Organization recognized this and developed guidelines for age-friendly health services, but they didn't actually give us the strategies of how to measure and how to implement. So we've been working with them for the last 2 or 3 years to first understand what is the capacity and the knowledge of these primary care clinics. So what do providers know? Have they been trained? And then talking as well to the patients and the potential patients. Why do they get care? What are their goals? And we've been working then with the public health system there, the primary healthcare board, and one of the health centers to actually develop some interventions that are going to be tested to see whether we can actually improve older people's accessing care and their outcomes of care as well, including things like screening for visual impairment, screening for hearing, as well as other things to make the sites more age-friendly. And what's equally exciting is because of the lessons that we've learned there, we're sharing that lessons with Rwanda, where we're actually starting a large project funded by the Institute to actually understand what are the needs in that country, but also with faculty at Northwestern who are working around issues around aging here in Chicago and in the US. And so we're learning from them as well as bringing back the lessons that we are learning. Now, as Bob pointed out, improving care for hypertension is a huge need and really a major killer in countries where we work. We've been working with the University of Abuja with Dr. DK Oji to really understand how do we actually integrate hypertension care into primary care in Nigeria. And when we went there and asked people, do you think this is a problem? Everybody in the room stood up and said they themselves, their siblings, their parents, their children, somebody had had a stroke or a heart attack. It was heartbreaking because we know what to do. We know how to prevent this. So again, bringing from the US, this was a model that was based in the Kaiser Family Foundation, the Kaiser Health System. Empanelment, task shifting to the community health workers, a simplified regimen, and testing home blood pressure. Apologies for the typo. But we also found that not everybody stays in care. So while that has actually been successful, we stumbled upon this new challenge. And this is actually showing how many people are actually remaining in care across the health centers. And so what we're seeing is that some of these health centers are actually doing pretty well, but some of the health centers are really struggling. And so we're applying implementation research through and with trainees that are funded with something called the CERTAIN grant, which is a research capacity building grant from the Fogarty Foundation that we have at the Institute to help them understand what are the challenges and, very importantly, what are the strategies we need to actually address that. And then finally, this is really, I think, one of the projects that I've really enjoyed because it's something that I didn't know much about. So I actually had no idea that this vision need was enormous. And in Dandora, which is a Kenyan community, there was the Brother Andre Hospital did they asked the community, what do you want? And they thought it was going to be, high blood pressure treatment. And they said, we want vision care. So we've partnered with them and with Notre Dame to train community health workers to use an app-based screening. It's very, very simple, can be used even with people that don't know how to read, called PEAK. And to date, we've already screened 1,267 participants. Sorry, that's actually outdated. It's actually now about 1,800. 78% of them are adults, 22% of them are children. And very importantly, over a quarter of the people that were screened needed some kind of glasses. And while there's some challenges about getting them to actually go to the hospital and getting glasses, 156 people have already gotten glasses to either address their reading problems, their near vision, or other problems such as myopia. And so this is something that we're talking about. How do we integrate this into primary care? How do we sustain that? And again, it's been done very closely with the community and with the public sector to see how can we advocate for this becoming a routine part of primary care. Then just sort of to switch gears a little bit. So I've talked a lot about how we're trying to help people understand and solve challenges, but at the same time, we're also very committed to really growing the next generation of primary healthcare providers. So we've talked a bit about growing the next generation of researchers through some of the grants we have. And so this is one example. This is Hillside Clinic in Belize. It provides greater than 10,000 primary care visits, as well as health educational visits. And this is all free to the people of Southern Belize each year. It's also been a very strong and active partner in our global health education. So we've had this opportunity for the students and the residents, fellow and faculty to learn while they're serving. And this is really across a wide range of disciplines. And since 2017, we've had 45 Northwestern individuals, both students, residents, and faculty who have worked at that site. And we're working to continue to expand that, as well as other sites that we have, including in the Dominican Republic, as well as looking for new opportunities, for example, in Rwanda, where we now have a agreement with the University of Global Health Equity. But at the same time, while we're doing this, we always want to consider, how do we make things better? And we're doing that both through research and more traditional quality improvement. So for example, we funded a demonstration project which said, well, if you do what we call point of care A1C, so again, this is a test to see whether or not you have diabetes and also whether your diabetes is under control. And rather than having people have to come in to the health center, we actually have in, for example, outside of the health center, people can go and test people in the community and say, hey, you might have diabetes, come on in. And for the people that have diabetes, reaching out and saying, hey, you're not that well controlled, let's see what you do about your medications, but let's also do cooking classes and health fairs to raise basic community awareness around diabetes, both prevention and management. And then equally exciting, respiratory infections do still remain a major cause of morbidity and death. And so, but this antibiotics are used too much, which is a big problem, both for cost as well as resistance. And so this is some work that's been led by Anita Moulier to look at, well, can we actually train people to use point of care ultrasound? So instead of x-rays, which they don't have, to actually use an ultrasound to see whether you can diagnose whether somebody has pneumonia and therefore needs antibiotics. So it's a very exciting site. We're doing two things there. So I'm just going to wrap this up and we'll move then on to questions, and just wanted to stop and say in gratitude, first to the Ryan family for their support and their trust and their confidence in funding this center, to Dr. Havey for his vision and dedication to primary care everywhere, to our collaborators now across 13 countries and growing, and then very importantly to the dedicated frontline providers everywhere who are really committed, working to ensure quality primary care for everyone, and to whom we are committed to helping to understand and address the gaps and to make sure that these new innovations and old innovations get to everyone, everywhere. And so I'm going to end here and thank everybody again and open this up for questions.
Thanks, Lisa. That was a great summary, and I hope the audience gets a taste of what we're doing. We could talk about this for hours. Lisa and myself meet for about 3 hours every month, and it feels like it's 3 minutes because there's so much to handle. I'll just, before we get to the questions, I'll just make a couple of quick comments. First, I've having a natural human cynical side. I sometimes, during times of fatigue and being overwhelmed, I wonder, why can't a lot of these countries do this themselves? And, the reality is that we've often used the term that health is wealth, and countries that are already impoverished, already unhealthy, really have populations that get stuck in a vicious circle of poor health, disability, early death, and then just, persistent poverty. Lately, there's been a lot written that as interest rates have gone up worldwide, World Health Organization and World Bank Organization loans to a lot of these low and middle income countries have just devastated them with this debt burden of interest, that they've dropped the GDP percent that they provide to healthcare. So this problem is not getting better from the local level, it's getting worse. And it means that institutes like us are needed more than ever. What else are we doing that gives everyone hope for the future? We are training the next generation of primary healthcare workers. That was pretty important to the Ryan family when they were motivated to fund the center. They really believe in primary healthcare in the US, and they want to see it promulgated around the world. We have a little bit of an issue of kind of inspiring people to stay in primary care. So I try to wave the flag a little bit, and I remind people that if Bob Havey, who started out as a regular primary care internal medicine doc more than 35 years ago, could actually just have a random idea almost 19 years ago to try to get involved globally, and built this sort of presence with the 400 faculty that have jumped along with me and Rob Murphy and Kate Klein to do this. If I can do that, then primary care must be a great field to get into, because look what you can do as one doctor to impact a lot of lives. So that's a point of pride for us at the Institute. It's a point of personal pride for me that we can get that sort of thing done. We know there's an obligation to get the work done. We also know there's an obligation to keep educating our audience and inspire you and let you see what your gifts are doing for us. So we, Lisa and I both are very grateful, as is everyone at the Institute. There are a few questions that I'm going to pass along to Lisa, and I may, pipe in a little bit as well. But I'll start with kind of an obvious first one, since we're coming out of a really awful historic pandemic, and ask Lisa, what do you feel the COVID-19 pandemic taught us about better primary health care?
So thanks, Bob. I think it taught us a lot, probably a lot of which we should have known, but I think it really brought us much more to the forefront, which is that if you have a strong, trusted primary care system and you have this sort of continuity of care, so people say, this is who I'm going to call, this is where I'm going to go, that's absolutely critical in the response to a pandemic. So I think initially a lot of things focused appropriately so on the need for the intensive care unit. But when it turned out that really what we needed to do was also support people who were well enough to stay at home, expand the use of the vaccines, and very importantly, keep people in care so that we didn't have people surviving COVID or not getting COVID, but then dying of a heart attack or having complications of diabetes. I think that's what we really realized, that people need to have that basis. And we certainly saw that in the US, but we really saw it in a number of countries. So I've worked in Rwanda for quite a few years, very, very strong commitment to primary care since soon after their genocide. And they had very little disruption in their primary care. They were able to respond quickly to the pandemic, and people kept on having access to care. So they had very little sort of additional mortality as a result of that. So I think it's this idea about creating primary care that is trusted, that people feel is welcome, and that has the ability to also serve as the front line in this pandemic and in future pandemics in, educating people, providing some of the initial screening that's needed. And then very importantly, as we see things, for example, like long COVID, something else that the Institute is working on, that you have somebody in primary care who's going to help you, before, during, and after the shock.
Thanks, Lisa. One question that came in from the audience was, how do we make sure that race and gender are included fairly in medical research and medical studies, and that the care that's provided around the world is administered in a sensitive manner? I think what sometimes at our events and when you watch our videos and you look at the local faculty at the Institute, it's not real clear to the audience how reliant we are on our partners. The reason we get done what we get done is because people like Lisa have been in the field for more than 3 decades, partnering with these low and middle income country leaders from their own health systems. We learned long ago, we are not dropping in, walking into a clinic for a week and leaving. We're building infrastructures, and we don't build this on an old, call it colonial attitude of we know better than you. We build it as partnerships, and we have incredible partnerships that we've built in over 40 low and middle income countries with the local universities. We've strengthened their health infrastructures. We've learned from each other. We've got trust that we've built. A lot of that's through Lisa, through Rob Murphy, who's been in the field over 20 years. So, there's no issue with equity with what we're doing, because we're not taking over. We are building these trusted partnerships that we learn from, they learn from us. One of the big things we're just about to start, and we're launching this next month, is we're going to build a base in Stellenbosch, South Africa. That'll be another jumping off point to more easily have our students and faculty have someplace to stay while they're going to a lot of our partner countries on that continent. So I could go on and on, but the equity issue may not look that apparent until you go into the sites where we work and realize that we're not just going in as a stranger, we're going in as a welcome part of the family in that community. Lisa, do you have any comments on that?
Yeah, no, I think really, really great question. And I think it sort of has I'm sort of hearing 2 parts, one of which is about sort of the research and the second is about the care. So I think, Bob's already talked about the care that that we ultimately don't control what actually happens. And so I think some of it is really just teaching some of the strategies. And when I talk to students who are just going overseas for the first time, I tell them they need to learn to listen and listen to learn. And I think that's probably some of the most important things, because it's understanding and helping people understand, well, why is it that turns out actually that more women come in for hypertension care than men? So let's figure out, why is it the men aren't coming? Are they they can't leave their jobs? Do we have to figure out new strategies? So some of it is understanding both what are why are there challenges, but getting people to understand what are some of the changes that might help in addressing them. We've just published a supplement that looked at how some countries were very successful in dropping under 5 mortality. But even among those successful countries, we still found inequity, so differences based on geography. So different parts of the country did better than others, and some of that was due to things like religion or ethnicity, but some of them had to do with the basic infrastructure. So some of what we do is to bring in a little, helping people with a pragmatic research lens to understand and then develop the strategies. In terms of the research, I think it's also a really important question. And I talk about power. And for those of you who do research or know about statistics, power is sort of the ability to actually find a difference if there actually is one. But there's other power that we talk about, and that's power on who's designing the research, who's doing the research, and who's engaged in it. And I think that really understanding, again, are we coming in and helping people address a problem that they have identified? Is it being done in a way that is allowing people to truly, in an ethical way, understand what something that works in one place works in another? So I think, again, it really takes deep partner engagement, which Bob's already talked about, and building that, and then coming in with being humble. So I think that's the other thing, is coming in there and really with curiosity and helping people to learn.
Great, thanks. A question came up asking, what are we doing in the center and at the Institute to kind of engage students and other primary healthcare providers from Chicago, and what do we expect the result of that will be? And I'll let Lisa take most of this, but we've been proud for all the years that our global health efforts have taken place, that we're the #1 med school in the country for medical student global health rotations. The original motivator was to do just what this center is focusing on, and that is to inspire med students to go into fields that really are primary healthcare rooted and based fields. And we've been successful. We've had a lot of people who have kind of seen what it's like to be at the bedside, to kind of be right there in the community and be part of kind of a continuity integrated system, and they've enjoyed that. I'm going to piggyback one second question on top of this and let Lisa respond, and that is, somebody probably because of the newspapers asked if the recent move in the US and even in the UK to unionize primary care, if that's going to impact anything. The way I view that, being so close as I am to younger docs in our system, and I do run recruiting here, so I talk to primary care candidates all the time. Doctors want to see patients. They want to be part of a patient's life. People go into primary care because they love the relationships, they love the continuity, they have a personal commitment to really seeing someone's health maintained and improved throughout their careers. The union thing is kind of, to me, it's the business of medicine, background noise of how people organize themselves as they go into their workplace. So I don't see that as a threat at all to what we're all trying to accomplish. So, Lisa, any comments on these?
Yeah, so the union one, I'm going to sort of leave to you. I do think it is important to realize that we have to, look at the well-being of our providers as they look at the well-being of their patients. And the rates of burnout is very high globally. We've actually done some measurement in other countries, and I think there's things that we can do to help with that. And so I think if the unionizing really allows people to get back to what they want to do. I always say that nobody gets up in the morning and says, today I'd like to provide kind of okay care, mediocre care, rushed care, too fast care. But people will get up in the morning and say, that's what's going to happen because I don't have the time, I don't have the resources, there hasn't been this sort of team-based approach. So, again, I can't speak to in the US as much, but I can say in other countries, there's sort of a growing recognition of the need to care for the caregivers as well as for the patients. In terms of the students and the faculty, I think that's one of the things that's been really fun. It was very difficult during COVID, as you can well imagine. Everything, all the stuff that was being built totally shut down. So we try to be very careful about when we send people over to be very clear about what they're doing. When I was a medical student, and I don't know, Bob, for you as well, but people would go over and they would do things that weren't necessarily appropriate in the sense of like surgery when they wouldn't be able to do surgery in the US. So we try to make sure that the students that go over are aware of what they can do, what they can't do, and that they're there to learn and hope and bring back sort of those lessons and hopefully inspire them to move forward. So we try to really make sure that we send them to places that are first and foremost safe, but that they'll also get a great experience in terms of understanding primary care and primary care needs in other settings. As people develop on in their career, then we look for other opportunities where people actually can do some exchanges. And for example, at the University of Global Health Equity, actually, we're going to host medical students from there, which is another really great opportunity for our students to learn, as well as sending students over there. And then finally, we have some who really want to go for a longer period of time. And so through some of the funding that we have, for example, the Fogarty funding at the Institute of Global Health, we have people going over to work in other health systems for up to a year doing research, but also sort of partnering and learning for that. And we're always on the lookout for new opportunities. We think we have another new one that we can send over groups of people to work together in the Dominican Republic. So always looking for new opportunities on that.
Thanks, Lisa. Lisa, I'm going to direct this to you, and I know the audience has already gotten a lot out of hearing all your comments, and I think I'm always inspired when I listen to you because of your, not just your commitment, but your broad experience. I mean, you're the right person in the right place to lead this center, and it makes me feel great about partnering with you. But people have asked a lot of questions about what's next. I mean, you gave them a little sampling. You could talk all day about this, but from your perspective, what are the next steps for the center, and how do you see the growth that you want to accomplish? What do you think would be our next moves?
So I think continuing to expand how we are really inspiring the current and the next generation of primary care providers here, I think is really something that we're committed to. We have a new associate director, Danielle Steeker, who's really working on that, and medical medicine and pediatrics junior faculty, JJ Parker, who's doing that as well. So I think that's sort of one area. I think we're really looking to continue to establish these what we call platforms. So these are institutions with whom we have multiple different collaborations to really strengthen and deepen that, whether it's through exchange of students or faculty, whether it's through capacity building, whether it's through grants. So Nigeria, University of Lagos is a great example. University of Global Health Equity, I actually been working with them since before they were university 10 years ago, is another one. And then, as Bob pointed out, Stellenbosch. And then really doing sort of deeper dives to be able to do these kinds of sort of 5 or 10 year commitments to see how we can really change things, initially probably at a local or subnational level, but integrated with the national work to be able to, be ready to scale. So be ready to spread, so that it's great if we can improve care at a hospital or at a district, but they were always thinking about how is that going to then expand out more rapidly to have broader impact. There's also a really interesting question that I think is another area that we do need to focus on, which was, it says, has the primary care initiative included diagnosis or treatment for depression, which is the total top 10, I think, causes of global burden of disease. So, people often talk about non-communicable diseases, and they say non-communicable disease and mental health. Mental health is a non-communicable disease, and it's chronic. And we have to think about how to integrate that in. So we're doing some work in the HIV community, mostly because we're partnering with a psychiatrist there, but also looking at other opportunities. For example, postpartum depression is a major burden in other countries as well. It's more difficult because hypertension is hypertension. The medications that work in Chicago are probably going to work in Nigeria, but how we even talk about and diagnose and address mental health and including depression is really something that has to be very, very contextually specific. So we're bringing in, people with other skill sets and patient-reported outcomes and sociology to figure out how do we actually do that, and really learning from our partners overseas. So I think that's certainly an area of growth. And then we'll just continue to work on the non-communicable diseases as they emerge, and thinking about how do we make care simpler rather than more complicated, using things, for example, like AI or other kinds of technology.
So, what are we doing with support and philanthropy and so forth? I mean, I think the audience knows, I say it over and over again, without philanthropy, without the gifts, we wouldn't have gotten anything done. So I hope everybody feels good about what their money supported. This is our 18th year. I've been grateful to everyone who's been involved all these years to allow us to get to this point. Remember, we had about 30 people who started in the global health work that I began about 18 years ago, and now there's well over 400, and we're growing quickly. It kind of starts to be exponential. But in terms of our future plans, we have one big retreat every year. I send a big kind of go team letter out that I just actually did last night. Lisa hasn't gotten it yet, so she'll get pressure from me like I give pressure to everybody, which is, let's talk big ideas. We've got a great infrastructure. We've got a lot we can get done. We can't do everything, but let's shoot for the moon. Let's go for big ideas and see what sort of funding that requires, what kind of impact it's going to have, how realistic is it. So we do things like that along with all of our other communications. We meet every single week as a center. So we put a lot of time into this. And, the impressive thing, if you think about it, is that everybody involved has another life, believe it or not. They have not just a personal life, but many of us have clinical lives. We have administrative lives. We have research lives. So there is a crazy, hard to believe element of volunteerism in everything we do. I mean, if you look at myself over 18 years, this has been maybe more than I expected it would take out of my life all these years, but look at what's resulted from it. So that's a lot of pride in the Institute. And I hope, again, the folks who have supported us understand that this is not something that anybody's doing for any personal reason, except just for the good of the project. Kind of hard in this world these days to think that somebody would put all that time in just for a good goal. And yet we've got, 400 leading to 500 people dedicated just to that aim. So that's kind of fun, kind of impressive, and makes me feel good about it. I hope it makes you feel good about it too. So I'm going to close with that and see if Lisa has any closing comments.
No, I think just to echo your thanks as well. The funding that's been given has really given us the freedom to be able to, work on things. We try to find the places where Northwestern has expertise and there aren't a lot of other people focusing, like healthy aging, like vision, places that people look initially say, why are you doing that? And everybody's very interested in what we're doing as well. It's also really helped us establish, track records that have allowed us to raise money from other things. One of the questions was about the Gates Foundation. We actually have a couple of Gates grants that really build on the fact that they understand and they trust the fact that we know what we're doing, and that we're doing in a way that's collaborative, and we're also producing what we call actionable evidence. So really getting lessons that, yes, they end up in papers as well because we are in an academic institution, but more importantly, that the impact is on policy and on practice. And we just looking to expand that, as we continue along. And so again, just really heartfelt thank you.
Okay, and I'll turn this back over to Jen to close this out.
Thank you so much, Dr. Hirschhorn and Dr. Havey, for speaking with us. And thank you so much for everyone who was able to join us today. If any of our attendees are interested in learning more about the Havey Institute for Global Health or supporting our work, please visit us online at globalhealth.northwestern.edu. We will be sharing this afternoon's recording by email after the event. And again, thank you so much for joining us, and we look forward to seeing you again soon.